Welcome to Exploring the GI System, or From the Gut to the Butt. My name is Beverly Tomasian. My pronouns are she, her, and hers, and I'll be leading this discussion today. I'd like to welcome all of you. Before I kick off with the official content, I'd like to do a land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda. And we recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this area. I also want to wish a very happy Diabetes Month to all of you and Diabetes Day. And I don't know if y'all know why we celebrate it's World Diabetes Day, November 14th. It's because that's the birthday of Dr. Banting. And Dr. Banting and Dr. Best and Dr. McLeod all worked diligently and tirelessly to help provide insulin to people living with diabetes in the 1920s. Dr. Grant was the youngest physician, Dr. Banting was the youngest physician to ever win a Nobel Prize in the year 1923. So without these amazing innovators, we would not have had insulin at such an early date, and they had very limited resources. So that's why we celebrate November 14th, because that's Dr. Banting's birthday. So, and November is a month dedicated to celebrating and recognizing people living with prediabetes and diabetes. And here is the miracle of insulin. Here we have JL in 1922, December 15th, living with type 1 diabetes. His pancreas doesn't make any insulin. He's not able to store glucose, protein, and fat. So without that hormone insulin, that growth hormone insulin, which is life-saving, we cannot thrive. So with insulin replacement therapy, by taking insulin injections 2 months later, this is the same little boy. So when I think of insulin, I think of hormone replacement therapy, and I think of it as a life-saving hormone, and I am forever grateful for this discovery over 100 years ago. We also are here to help. This is my team, or our team at Diabetes Education Services. We have Brianna and Tiffany. They are dedicated to providing the best customer service possible, and we are committed to making sure you have the best experience possible. So please feel free to reach out by email, by phone. We want to hear from you, and we want to support you on your journey, or just to help navigate our website. I also like to say that our company, Diabetes Education Services, is a value-based company, and we are committed to providing diversity and inclusion in our educational offerings. So that's part of our values, and throughout our programs and our content, we are really thoughtful about addressing social determinants of health and taking a person-centered approach. As far as conflict of interest, I have none to declare. I do want to let you all know that where did this information come from? I do a lot of research and reading, and so there's many articles I've cited on the slides, but I also read these 3 books. One is called Gulp by Mary Roach, Adventures on the Alimentary Canal, which is it's pretty interesting. Gut was much more helpful. It was written by a medical student, and as she was studying the GI system, she wrote kind of this love letter book about the intestines and the gut. Jill Enders, and then Bob Knight, who actually got me started, or Rob Knight, on this whole adventure looking at gut bacteria. He's a TED speaker and a very well-known researcher in the field of gut bacteria and intestinal health and overall body health. He wrote this book, Follow Your Gut, which inspired me to really investigate the relationship between gut health and diabetes more closely. And so you never know what's going to spark that interest, but once you get hooked on this topic, you just want to keep learning more. It's so intriguing. Let's take a look at our learning objectives. We're going to explain the links between diabetes and oral disease. We'll look at the correlationship between hyperglycemia and the gastrointestinal system. We'll look at the pancreatic exocrine dysfunction and in diabetes. So we talk about endocrine dysfunction often, but also we're going to look at exocrine dysfunction. Now, somebody's asking if this webinar will be recorded. Yes, it is going to be recorded. We'll list the new nomenclature for screening guidelines and how we discuss liver disease. We'll look at the endocrine function of the intestine and the importance of a healthy microbiome. And most important, we're going to enjoy a state of wonder. Many of these concepts, are well researched and well understood, but some of them we're still gathering information. And I think this is amazing that we've really recognized the intestines as an endocrine organ in the past decade, where it's releasing all these different chemical mediators that are influencing our overall health, our glucose, and so many other functions of our body. So I think in the past, we just kind of thought about our intestines as helping with digestion, but there's been an expansion of the role of the intestines and the link between our gut and our brain health, and the link between our overall health and the nutrition that we consume. But let's start with the embryo. So when we think about the embryonic starting point, we're kind of like three tubes in the beginning, the ecto, the meso, and the endoderm. Now, the embryonic endoderm is what I'm going to focus on today. It develops into the interior linings of two tubes in our body: the respiratory tube, which we're not going to really discuss, but the digestive tube. So the digestive tube from the endoderm differentiates and develops into the salivary glands, the esophagus, stomach, small and large intestine, liver, gallbladder, pancreas, thyroid gland. And if you think about conditions correlated to diabetes, insulin resistance, metabolic syndrome, it involves a lot of these organs and these glands and the thyroid. So it kind of just makes me think about this interconnectivity to these different conditions that people with diabetes have, starting from an embryonic standpoint. So where does eating start? Well, it starts with the eyes. And when you look at this food, your brain is automatically sending signals. Your eyes are sending signals to your brain to understand, what does the body need to prepare for this consumption of food? What does it need to release as far as hormones and other enzymes? So the eyes see the food and make appraisal for the incoming load. And then the glands in our mouth secrete saliva to prepare for chewing, and then we release in our saliva and our mouth enzymes like amylase to help with initial digestion, and then we chew. And that's why teeth are so important. I just was working with the person yesterday, and he says, yeah, I just miss nuts so much. I'm like, why do you miss nuts? He goes, I've lost all of my teeth. So, that dentition is important, and then it creates a bolus. And then the upper pharynx and esophagus are under our conscious control. We're going to push the food back with our tongue, but once it passes the pharynx, now it's under involuntary control. The esophagus and the smooth muscles are actually controlled by our brain. And then as it goes down the esophagus, it has to pass through that sphincter, the esophageal sphincter, to enter the stomach. And then, of course, esophageal sphincter is so important to prevent gastric reflux. So if you get your little typing fingers ready, if you want to type in what the answers to this question. So JR thinks that their ability to taste food has diminished recently. They ask you, what are the 5 confirmed basic tastes of the tongue? So I want to ask you all to type in, what are the 5 flavors? I'll wait like 1 second. I'll wait 3 seconds. And there's a little delay from when I ask the question to when you actually type it. So maybe you think about them and start typing, but I'm going to reveal the answers right now. And the answers: sweet, sour, bitter, salty. And look at bitters in the back, sours on the side of our tongue, sweets on the tip of our tongue. And then we have umami, which is known as a savory flavor. And this actually was discovered in the 1920s, but it took like almost 80 years of the scientific community to acknowledge that umami is a flavor. So we finally got it in there. And now there's some new work being done at USC where they're discovering that maybe the tongue might also be able to detect ammonium chloride. And that's found in certain foods like this licorice in the Netherlands that has ammonium chloride, some amount in it, that's people can taste it and detect that flavor. And they think maybe this is an adaptation from an earlier version of ourselves to avoid harmful substances. So this is the 5 we know about now. There might be other flavors that we detect that might be discovered in the future. So let's take a journey down our alimentary canal. And you can see, I just put this picture. This was from my old anatomy book when I was in nursing school over, 30 plus years ago. But we started with the oral cavity, down the esophagus to the stomach, and then we have the pancreas, the gallbladder, and the liver, and then we head into the intestinal area. But before we go down that road, we're going to hang out in the oral cavity. And if you have a question, okay, great. I see you all popping comments in. That's so helpful. But if you have a question during this presentation, you're welcome to type it in. And if it kind of matches what I'm talking about and I can, address it during that moment, I will. Otherwise, I'll answer questions after class. Okay, we're going to go to the oral cavity, and I have a poll question for you. Diabetes is associated with an increased risk of oral disease. Which of the following statements is true? People with diabetes benefit from vinegar gargles to decrease bacterial load. B, people with diabetes are at greater risk for tongue cancer. C, 1 in 5 cases of tooth loss is linked to diabetes. D, diabetes is associated with increased tonsillitis. And if you haven't done a poll question with me before, just want to say, choose what you think is the best answer. And if you don't choose the best answer, it's totally okay. Because I don't know about you, I've learned the most from choosing the wrong answer, metaphorically and literally. So no matter what, it's a learning opportunity. And nobody knows what answer you chose. So it's confidential too. All right, we'll take a few more seconds. And I'll go ahead and close. So take a risk, choose what you think is the best answer. 63% of you voted. All right, I'm closing the poll. Thank you. Let's see, 3% of you said A, 9% B, 6% D, but most of you chose C. Is that the best answer? Yes. So we know that people with diabetes have a higher risk of having tooth loss. People with diabetes have a higher risk of cavities, abscesses, gingivitis, because there's extra sugar in their saliva. And so let's take a look at that a little bit more. People with diabetes have higher levels of glucose if their blood sugars aren't on target, and those higher levels of glucose lead to more dehydration. So the kidneys are going into high gear trying to get rid of all that extra sugar. Along with sugar goes water. So people with elevated blood sugars are chronically dehydrated, and they might actually say, I'm really thirsty all the time. And I can tell when people come in to see me, like I work at Indian Health Services Clinic on Fridays, when they come in to see me and they're makes total sense to me. But saliva has a really important function. It cleans the teeth, it lubricates chewing, so we can create a bolus of food that can go down our esophagus. So, and saliva protects against bacteria buildup. It's really, really important, saliva, as it turns out. So when we have elevated blood glucose levels, there's more sugar in our saliva, and then the saliva starts sugar coating our gums and our teeth. And it can increase the risk of infection and really leads to chewing difficulties. So we can see here's a healthy gum line, here's periodontitis where there's inflammation, there's bacteria buildup, there's recession of the gums. It's not only affecting the gums, it's also affecting the structural ligaments and support structure of the mouth. And this can lead to real damage to the teeth and loss of teeth also. Bone gets destroyed. More severe and prevalent diabetes and elevated A1C is associated with periodontal disease, and treatment of periodontal disease helps decrease blood sugars. I work with a lot of people who have limited resources. They're not able to see the dentist on a regular basis, and they have a lot of gum inflammation and tooth loss. And so I always am trying to hook them up to a place where they can receive dental care so that we can help protect their gums and teeth. And also at the same time, we're trying to lower blood glucose levels to prevent that dehydration, dry mouth, and extra glucose in the saliva. So we know this is bidirectional. People with elevated blood sugars have more periodontal disease. People with periodontal disease have higher rates of diabetes. And actually, dentists and dental offices are getting more involved with screening people for diabetes because they're oftentimes the first people to recognize it. Oral care matters. See dentists at least yearly, hygienist twice yearly, brush twice daily, floss daily. I bring this up at every visit with the people I serve. So important. We know that if there's extra bacteria in the mouth, there's so many capillaries that those capillaries go ahead and the bacteria jump into the capillaries and they enter the circulation and they end up in the heart vessels. So then the bacteria attach to the fatty plaques in the coronary arteries, leading to clot formation, inflammation. So hyperglycemia equals gingivitis equals heart disease. We want to do whatever we can. So when we see this red lining around the gums, that's a sign. Let's get in there and start flossing and brushing. The best $10 you will ever spend is right here. I mean, there's studies that show that people who floss and brush their teeth live longer. It's hard to know if it's just because of that, because people who brush and floss tend to do more, they're more actively engaged in their health overall. But just decreasing that bacterial accumulation in our mouths can make such a big difference. So I just wanted to mention for our clinic, if you're a new patient to our diabetes program, we give everybody a toothbrush, toothpaste, floss, and we also give them diabetes socks and a nail clipper. They love it. It's so wonderful and it's inexpensive for us. And it's just showing that we have a commitment to their health and we're encouraging them to be actively involved in their health too. Just some ideas. Okay, so we made it through the oral cavity. Let's go to the stomach and beyond. So here in the stomach, we have the fundus, upper part of the stomach, and after we eat, it passes through the sphincter. The food kind of enters this waiting pattern and it sits up there in the fundus, waiting to be utilized and digested. Then we have the pancreas sitting right underneath, and the gallbladder with the common bile duct where the pancreas and gallbladder release their digestive enzymes through the ampulla of Vater, which we'll be coming to later. But before we come to that, let's ask another question. What is the best definition for borborygmi? Is it A, a tropical fruit used for nausea, B, stomach rumbling, B, gastric reflux, or D, treatment for constipation? Borborygmi. I just love saying that word. Someone's asking if the slide deck will be available. It's available on the right-hand side of your screen. You can download it, or we send an email out. Then it has a PDF to the slide deck. Oh, you all are doing a great job. Okay, take a few more seconds, and I'm going to go ahead and close the poll. Share your results. 86% of you chose the best answer. It is stomach rumbling, borborygmi, and it's so funny because people feel embarrassed about stomach rumbling, but it's just a very natural part of digesting our food. So let's just take a look at food digestion. So as I mentioned, as it comes through the esophagus, the food sits in the fundus. It serves as a holding and mixing area where the gastric juices are released and they start breaking down our food down into smaller particles. Then the stomach, through borborygmi and the squeezing and the muscle movement, move the bolus to the lower regions, and they're broken down into smaller particles through stomach acid and motility. And then we hear that gurgling and stomach rumbling is audible. It's a reflection of that movement. Now, this is really interesting to me that I did not know there's a very precise calorie consumption of food or caloric passage of food. And I'll just read my sentence. The usual meal takes about 4 hours to pass through, or 1 to 4 kilocalories per minute are digested. So this is very precise. And so the stomach is moving the stomach contents through in this very kind of thoughtful manner based on kilocalories. interesting. So people with diabetes, I just want to say something. Some people with diabetes will move the stomach contents more quickly through their stomach. And then people with gastroparesis might move the stomach contents more slowly through their stomach. But very interestingly, that people, especially with newer diabetes, might actually have more quick stomach emptying than the 1 to 4 kilocalories per minute. And that might lead to increased hunger. And we know that people with diabetes, might not be making adequate gut hormones, which we'll talk about in a minute. So kind of all goes together. Carbs take a few hours to pass through, but protein and fatty meals can take up to 6 hours. So of course, there's a lot of factors that influence how quickly we digest food. For example, then, if we are saying that it takes 4 calories a minute to digest our food, if we eat 400 calories, that means it's going to take about 100 minutes to digest our food. If we consume 1,000 calories, and we're doing 4 calories a minute, that means it's about 4 hours to digest our food. So it's the amount of calories we consume, and it's also the mixture of protein, fat, and carbohydrates. That's all going to influence how quickly our post-meal blood sugars elevate. And then it's going to see, do we have more quick gastric emptying or slower gastric emptying? So when people say, why are my blood sugars doing this after I eat? Like, it's complex, right? There's a lot of different factors influencing postprandial blood sugars. And this is just one of the many factors that is influencing it. Now, some stomach issues that we might have come across that I just want to discuss, because people with diabetes have more GI issues, kind of thinking about that embryonic tube, how it's all coming, that dysfunction throughout that embryonic endoderm tube seems to affect many parts of that later in life. I want to talk a little bit about Bruce Springsteen. Now, why do I have him in my slide deck? Well, as it turns out, the boss canceled his tour. And he delayed it, actually, and he's actually performing fine. But he canceled it because he had peptic ulcer disease. Now, I don't know any details about the boss, like what causes peptic ulcer disease, but I'm thinking he might have had H. pylori. Now, I want to talk about H. pylori because H. pylori has been identified now. Like we all know that it's a cause of peptic ulcers and stomach ulcers, duodenal ulcers, but it took a long time to figure this out. This Dr. Barry Marshall actually was talking about it 20 years before it was recognized. And he kept saying, I think it's not, we used to blame stomach ulcers and duodenal ulcers on the person is stressed, they need to do relaxation, they need to calm down, they need to quit their job. Like, we were blaming the person, and we were doing a lot of surgeries for stomach ulcers. But Dr. Marshall said, no, it's not because of stress. It's because of this bacteria, H. pylori. He was doing studies in his research lab, but it wasn't being accepted by the medical community. Finally, he takes a petri dish full of H. pylori, drinks it, gets H. pylori infection, and then he treats it with a series of antibiotics and milk of magnesia, and he documents all of this. Finally, the medical community started listening to him. So it took him having a big gulp of H. pylori to turn the tide. And that's why I want to say to all of you, never give up. Whatever you believe in, you think is right, keep pursuing it. So he did win the Nobel Prize in Physiology or Medicine in 2005 for finding the link between H. pylori and gastric ulcers. But as I mentioned, it took 20 years. So I just want to say, in most individuals, H. pylori infection is asymptomatic, but in about 10 to 15% of infected individuals, they will start getting peptic ulcer disease, inflammation, and that bacteria, the H. pylori, is relentless. It just digs into the mucus lining and it starts eating the mucus lining of the stomach. And you could see here, there's a gastric ulcer, and here duodenal ulcers are actually pretty common too. And this can lead to bleeding into the intestines and cause all kinds of problems. Very uncomfortable, very painful, and can lead to also increased risk of stomach cancer. So wait, let's talk about H. pylori a little bit, because it's a well-known coexisting bacteria with humans. We've co-evolved with H. pylori since the beginning of time. And as a matter of fact, 50% of the world's population coexists with H. pylori. And it's actually one of our disappearing bacteria. Children now are being born without H. pylori, and we're not sure how that's going to manifest in digestion and absorption of nutrients. More data is needed. So most people don't even notice. It doesn't cause problems, but sometimes the H. pylori goes rogue. I don't know why, and I don't know if they know why. It just goes rogue, and it starts attacking the stomach membrane. So in a small percentage of people, it causes inflammation, and the main symptom is an aching or burning in the abdomen, which might be worse with empty stomach. So if you're working with people and they're having stomach issues, because the reason is, and you can see right here, people with diabetes are at higher risk for H. pylori, and people with H. pylori are at higher risk for diabetes. Again, it's another bi-directional relationship. So if they're saying, gosh, my stomach's empty, it really hurts, or I have fullness or bloating with fluid and solid food, hunger and empty feeling in the stomach 1 to 3 hours after the meal, mild nausea, weight loss, burping, darker tarry stools, which means, of course, they have a bleed. This is something to consider. Let's evaluate them to see if they have H. pylori, because we want to stop it from progressing and potentially causing peptic ulcer. About 10 to 15% of people with an H. pylori infection, so when it goes rogue, develop peptic ulcer disease, and about 1 to 3% develop stomach cancer. The treatment is 2 antibiotics along with another medication to help protect the stomach, but those antibiotics are taken for a few weeks, and it's a pretty effective treatment. I think 80 to 90% of people on that treatment get rid of their H. pylori. So just want to, as we're working with people with diabetes, I'm going to tell you, a lot of people when they come see me, they're worried about their diabetes and eating. Those are the two things they're really concerned about, but they often complain of stomach issues. And so we might pick up on some things that maybe are missed by the person or the provider, and we can support that person in getting that discovered. Okay, JR has lived with type 1 diabetes for over 30 years and has been complaining that they feel full and bloated after eating and experiencing more post-meal hypoglycemia. Based on this information, what is the most appropriate recommendation for JR? They evaluate transglutaminase levels. B, encourage small, frequent, low-fiber meals. C, suggest a consult for gastric pacemaker. D, recommend they try avoiding foods with gluten for a few weeks to see if they feel better. So JR, type 1, for 30 years, has been complaining that they feel full and bloated after eating, experiencing more post-meal hypo. What is the most appropriate recommendation for JR? Let me launch this. Should we evaluate transglutaminase, encourage small, frequent, low-fiber meals, consult for a gastric pacemaker, or try avoiding gluten-rich foods for a few weeks? All right, we'll take a few more seconds. Okay, I'm going to close the poll and show you results. So 20% of you said A, 20% of you said D, but most of you said B, encourage small, frequent, low-fiber meals. So let's just take a look at this question. They have type 1 for 30 years, and after they eat, they feel bloated. So why would a person feel bloated? Well, maybe that food is just staying in their stomach. It's not moving forward. And actually, they also have post-meal hypoglycemia. So a person living with type 1, whether they're taking injections or using an insulin pump, they check their blood sugar before they eat, and then they see what their blood sugar is. They count their carbs. They give themselves insulin based on the food they're going to eat. But if the food doesn't move from the stomach to the duodenum, that insulin is working, right? The insulin is lowering the blood sugars, but the food isn't moving into the duodenum and being utilized and broken down into glucose. So now we have a mismatch. The insulin's working, but the glucose isn't rising. So they keep getting post-meal hypoglycemia. And that's a very common sign of gastroparesis, along with bloating and burping and just feeling super nauseated after they eat, feeling like their stomach's full, because it is. They have very delayed gastric emptying. So the best answer for that situation, gastroparesis, is eating small, frequent, low-fiber meals. The transglutaminase is going to look for celiac, as well as D, avoiding foods with gluten. Looks for celiac, which is an intolerance to gluten. That gluten intolerance doesn't usually, I haven't heard it lead to post-meal hypoglycemia. They can feel bloating after meals, but we have these two symptoms together that really indicate gastroparesis. And especially for somebody living with type 1 for 30 years or older, their risk is going to over for 30 years or longer, their risk is going to increase. We know that gastroparesis, which is just what it sounds like, paralysis of the stomach. So the nerves that innervate the stomach and tell the stomach to move the gastric contents forward are slowed down. And oftentimes that sphincter the pyloric sphincter is stiff and damaged. We'll talk about that in a minute. But gastroparesis affects 20 to 30% of people with longstanding diabetes. So, and gastroparesis comes in various forms. It can be mild or more intensive or really severe. And the signs and symptoms include early satiety, fullness, vomiting after meals. And how do we know a person has this? Well, they go to a GI specialist, where they do gastric emptying studies, and then we get more data and we see how their blood sugars are responding. And gosh, y'all, we don't have very good treatment. The number one treatment is get those blood sugars to target, number one. And then we're going to suggest small, frequent meals. You might want to do lower fat meals so the digestion is not slowed down, but we really want to make sure they have high nutrient meals to make sure they don't, struggle with undernourishment. But most important is really getting those blood sugars to target. So anybody who has gastroparesis, we want to make sure they see a registered dietitian to do an evaluation and help them create a plan to deal with this. We're going to be seeing a GI specialist. We're going to evaluate if a multivitamin supplement might be helpful for them. And then we might really encourage liquid or pureed calories. And I would say for a lot of people that I work with, we'll start with a liquid meal so that way it can be easily digested and absorbed by their stomach to protect against that post-meal hypoglycemia, and then followed by a food that takes longer to chew, but really focusing on high nourishment, lower fiber. And many people with gastroparesis might actually take their insulin after a meal. So they might take, and some might take a little insulin before the meal and some insulin after the meal, kind of based on their history of when they actually absorb the nutrients. So we're going to have to create customized plans for people with gastroparesis, encouraging them to chew their foods well. Make sure to sit up for 1 to 2 hours after eating to allow for gravity to help move the stomach contents forward into the duodenum, and so providing supportive care. There are gastric pacers where they would, in some regions of the country, they do it more than others, but it's like a heart pacemaker. It's an electrical device that stimulates the stomach to move the stomach contents forward. That has been helpful for some people. You kind of, if you read about it, you'll see mixed reviews, and not many centers across the U.S. provide this. But another intervention that I've run into recently is a gastric peroral endoscopic myotomy, or GPOM. And I don't know if you've heard of this, but actually a person that I work with in my county, and I live in a very rural county, he's lived with type 1 diabetes for over 40 years, such severe gastroparesis, it lands him in the hospital every few months, and vomiting, and he just can't utilize his food. And so a provider said to him from one of our local research universities and hospitals, said, why don't we try the GPOM? And he mentioned it to me and asked me what I thought about it. And I said, I don't know, I've never heard of that. So of course I went online and looked it up. And it turns out that Hopkins Medicine is actually doing these surgeries in other centers throughout the United States. It's kind of gaining momentum, where they actually cut the muscles near the pyloric sphincter. So let's just talk about this a little bit. So we know the gateway from the small intestine to the duodenum is that pylorus and the pyloric sphincter. The food actually, once it's in the stomach and ready to move forward to the duodenum, lets the pyloric sphincter know, hey, I'm ready to enter the door. So what if I have gastroparesis? Well, the doors that usually open very easily are kind of stuck and they don't allow the food to move through. So when that sphincter is stiff and closed shut, this little myotomy, which cuts some of those muscles and provides an opening, can allow the food to pass through. It does help to permanently relax the sphincter so the food can move freely. And I'll just, from my experience and doing research on this, the person I was mentioning, he just says his life is transformed. His food, isn't stuck anymore. It's actually moving through his intestines and he feels so much better and he's not so afraid of eating. So that, was a success for him. And, maybe it's a treatment that we can just, when we're thinking about how do people deal with gastroparesis, it's just one of the options we might want to share with somebody and, kind of research more and keep track of how it's going and look at more. We need more data because it's still pretty new. But man, any option for people with gastroparesis, we certainly want to have it in our field of consideration. Well, I thought we're halfway through. I usually do a stretch break, but given the topic, I thought we would do a digestion break to digest the material. Okay, I'm going to roll my shoulders back and I'm going to go ahead and touch my feet. I would encourage you to touch your feet too. Oh, yeah, we're good. Get more blood to the brain, and we get more blood to the brain, our cognition improves. And yeah, so let's keep going. We were talking about gut hormones earlier, and as we know, our gut hormones are so important in helping us regulate how quickly we move the food from our stomach to our intestine and helps us regulate how our sense of satiety, blood glucose, post-meal. So the gut hormones are actually secreted by the L cells of the intestine, some in the small intestine, but more in the larger intestine. Now, the interesting thing is people with type 2 diabetes make about 50% less gut hormones than someone without diabetes. And there was a new study published about a year ago that shows that people with type 1 diabetes may actually benefit from GLP-1 therapy early in diagnosis. So these are people with new type 1 diabetes and they're still in the honeymoon phase. And the honeymoon phase means their pancreas still is producing some endogenous insulin. So these newly diagnosed individuals, and it was a small sample group, less than 20 people, they gave them not only insulin therapy, but they added a GLP-1 to the insulin therapy. And by doing that, these people with newly diagnosed type 1 diabetes needed much less insulin to manage their blood sugars. And so what does that say to us? Well, we need to follow these people for years to see over time as their honeymoon period ended, did the GLP-1 still help them, or do they just really need to rely on insulin? So we need more data to really explore this. But I think it opened our view that maybe people living with type 1 diabetes might also benefit from GLP-1 therapy in the future. Right now, of course, GLP-1 therapy is off-label for anyone with type 1 diabetes. That would just be through, provider approval based on the person's situation. So I just wanted to mention that. And the other thing that we found out that this class of medications, the GLP-1s, can actually slow down peristalsis too much, and in certain individuals lead to ileus or intestinal blockage. So that's another thing we want to let people know. If you're having trouble where you're feeling like things are not moving, you have abdominal pain, and you're not having a bowel movement for more than 3 days, and you're on this class of medication, we need to know. But here's a diagram of the GLP and GIP hormones. So the GLP-1 hormones are over here on the left, and you can see it's affecting our sense of satiety. It decreases food intake. It can cause some nausea. And nausea might be co-associated with feelings of fullness. And then it can help decrease body weight. It increases from the pancreas insulin and decreases glucagon. So insulin helps lower the blood sugars. Glucagon raises blood sugar, so it helps decrease the post-meal glucagon, slows gastric emptying, and systemically, it reduces overall elevations in blood sugar and increases insulin sensitivity. The GIP, which is the GLPs, and we'll talk about in a minute, but the combo therapy, the twin cretin, Mounjaro, has GLP plus GIP, and it has complementary actions to the GLP-1. And so these two hormones together help regulate postprandial glucose, satiety, and nutrient absorption. Very important. So if we are lacking in these hormones, it can really affect the post-meal glucose. So here we have, and these are our medication pocket cards, are currently available GLP-1s that are listed here. And it has this interesting term, incretin mimetic. Incretin means gut hormones. So these are gut hormone imitators. And when they're delivered, we can deliver them through injection, and we have one here, the oral tablet that people can take on a daily basis. Then it's just replicating what our gut hormones were designed to do. So really interesting and, profound medication that we've added to our diabetes treatment plan, because it's really helping people not only lower A1C. Now, the GLP-1s lower A1C up to 1.6%, but the twin cretin, the Mounjaro, we're seeing up to 2.4% weight loss with the GLP-1s, 4 to 6%, the twin cretin, 7 to 13% body weight loss at max dose. So, wow, these are, they've just really helped us not only with diabetes management, but also helping lower body weight. And people who have steatosis or extra fat in their liver, it's helping to decrease that too. We'll get to that in a minute. And it decreases the risk of cardiovascular death, heart attack, and stroke. 3 of these are approved for pediatrics. So exenatide, Victoza daily, and the once-a-week Trulicity, approved for pediatrics. And this is kind of sad, right? That so many more children are getting in type 2 diabetes, but what an option to have just a once-a-week injection with the extended Trulicity to help them get blood sugars to target and also to support healthy weight. Of course, as I've mentioned, these are not a panacea. People have side effects to these: nausea, vomiting. If they have a history of gastroparesis, it's not a good match for them. We have to watch for intestinal block. There is, early on, they were saying it might be co-associated with increased risk of pancreatitis, but that doesn't seem to be the case at all. People with diabetes are at increased risk for pancreatitis in general, but these don't seem to increase that risk. We also have to monitor for any, people with a family history of medullary thyroid tumor. This would not be a medication we would use for them. So this grouping of medications has really changed the playing field of diabetes and weight, and is really supporting with weight management. But I want to mention something else, and that's metformin. Now, metformin has been around a long time, and many people are, metformin is the most commonly used medication for diabetes worldwide. A few reasons: it's very cheap, very effective. It's going to lower A1C 1 to 1.5%. It helps with LDL cholesterol levels, and it has some other benefits we're just starting to understand. And one benefit, some of the other benefits include induces GLP-1 secretion. What? So metformin will actually help increase the secretion of our gut hormones. It can change the ratio of our bacteroides to firmicutes. So these two classes of medication of bacteria, we want to get them in the right ratio. So it will improve the good gut bacteria. Wow. And this is interesting to me because people often complain of metformin causing diarrhea. And I wonder if in part it's because of these rearrangement of bacteria and increasing more healthy bacteria. I'm not really sure, but it's certainly something to consider. And it helps increase our availability of Akkermansia muciniphila. Now, we'll talk about this in a minute. And bifidobacterium. both of which are fantastic bacteria for our intestinal health and our body health. So metformin, again, decreases overall body inflammation and can improve the diversity of our gut microbiota. And just kind of talking about Akkermansia mucin and we call it AK for short, just so you know. So if you want to be hip, you just call it AK. Now, here is our intestinal barrier. So here we're looking into our intestinal lumen. Here's the bloodstream. Here's the lamina propria. And here's our intestinal epithelium. And here's the inside of our intestine with the mucous membrane. So here's the mucous membrane, and you can see all the bacteria living in our intestine. And this mucous membrane turns out to be really important because you can see here on the left, the mucous membrane is healthy, it's thick, and it's not allowing for the bacteria in our lumen to enter into our bloodstream. But over here, there's less of a mucus lining, and there's actually disruption of the intestinal barrier. And then look at the bacteria sneaking through because there's not enough mucin and getting into our circulation. Some people might call this a leaky gut. That's just one term that's used to kind of describe this. But we know that Akkermansia mucin is very effective in maintaining this mucus lining. And mucin, mucus lover. That's what it means. So we know that our mucus lining is inversely correlated with weight and diabetes in both mice and humans. That is, the thicker our mucus lining, the lower our risk of diabetes. The thinner our mucus lining, the higher the risk. We want to increase the mucus lining. It's a protector and increases the presence of short-chain fatty acids, those butyrates. So we want to increase butyric acid in the intestine because that lowers the pH and decreases inflammation. So yes, we love that. And high levels of A mucin is associated with improved health. We know that AK is associated with enhanced intestinal barrier function and incretin secretion from intestinal endocrine cells. Together, these actions suppress obesity, insulin resistance, and intestinal inflammation. So how do you get more AK? Well, fiber. Fiber is the new F word. Just eat fiber. It's so basic, but it's so important. We eat, I think right now in America, we're at 70% of our food consumption is processed foods, and any processed food, anything that comes in a package is low in fiber. We want people to eat whole foods. That's, foods that come from the earth that have more fiber. Let's talk about metabolic surgery. Now, metabolic surgery is considered as an option. It's considered, not recommended, considered as an option to treat type 2 diabetes for candidates with a BMI of 30 to 34.9, and we reduce this by 2.5 kilograms for Asian Americans. So Asian Americans at lower BMI have higher visceral adiposity. So we can try a Roux-en-Y, where we make a little gastric pouch and we bypass the duodenum and we create a jejunal anastomosis. So decreasing the absorption of nutrients in the duodenum. We can do a gastric band and shrink the gastric pouch. We can create a gastric sleeve where we cut the stomach in half and just have so much less space for consumption of food. So there are different strategies to do this, and we do actually recommend it as an option for people with a BMI of 40 or greater, or in this category if they can't achieve weight loss. So many people might utilize a do a trial with the GLP-1s first, or the twin cretin Mounjaro, to see if we can get weight down. And if that is not successful, certainly metabolic surgery is an option. Now, the thing I want to say about metabolic surgery in relation to gut hormones is that right after this gastric bypass, the GLP levels in the blood increase dramatically. So something about the surgical intervention increases the gut hormone availability, because you'll notice right after surgery, people's blood sugars drop. And sure, it could be because they're eating less, but even before they lose weight, you'll see that their blood sugars really improve. So people with metabolic surgery for weight loss experience remission. About 30 to 63% of those with the Roux-en-Y, where they bypass the duodenum. 35 to 50% of those who go into remission experience recurrence, but they have a period of about, I would just say on average from the studies I've read, 6 to 8 years without diabetes. So this is interesting. So if you can maintain euglycemia and you don't need medications to treat elevated blood sugars for 6 to 8 years, you are protecting blood vessels. It reduces the risk of diabetes complications. It reduces mortality and morbidity. More studies need to be done, but it seems like gastric bypass surgery is giving people a longer life and less complications. Of course, many people will go ahead and their blood sugars will elevate over time as a pancreas makes less insulin, but they still had that kind of diabetes vacation for that 8 years. That is very vessel protective. And here's some disadvantages, of course, for metabolic surgery. And so it's always this real thoughtful discussion with the person if this is the path they want to go, knowing that it's a lifelong commitment to manage, this alteration in digestion. And certainly connecting with a registered dietitian is going to be super important. Overall, weight is a heavy issue, and I just want to read this to you. And if you've been with me before, it's one of my favorite slides regarding weight. This scale will only tell you the numerical value of your gravitational pull. It will not tell you how beautiful you are, how much your friends and family love you, or how amazing you are. So weight, such a big issue. The American Diabetes Association says we don't have to weigh people at each visit anymore. At least once a year is what they recommend. And they also say that people have the option not to be weighed. The thing is, what do we do with that information? Is that information going to change our clinical intervention, our clinical practice? Do we really need that weight, or can we talk to the person and ask how they're feeling and how they're feeling in their body? Would that be a better assessment for us with that visit? So I think we're really changing the way we engage with people around weight, and we really want to be body positive, which I think is so wonderful. And there's a big movement, health at every size, that weight is not the only determinant of a person's overall health. It's just one metric out of many. Okay, I'm gonna keep going because there's a lot to say on that one. Let's move on to the duodenum. The duodenum is a really important part of digestion, where much of our nutrients are absorbed in the duodenum right here. And the duodenum is kind of a fuzzy part of our intestine. It doesn't like a lot of food lingering there. It's gonna go ahead and just break down the nutrients and move it on down. And once they get it to the large intestine, and it likes to keep itself nice and clean. So the duodenum, yes, kind of fussy. Here's our pancreas again, and our gallbladder, bringing in digestive enzymes from the pancreas and bile from the gallbladder through the ampulla of Vater, helping to break down proteins and fats and other nutrients in the duodenum. So they're really getting broken down here and to be utilized for energy. The thing I want to talk about is, pancreatic dysfunction is more complicated than it sounds. Like, there's different types of pancreatic dysfunction. We talk about type 1 diabetes and autoimmune destruction of the pancreas. We talk about type 2 diabetes, where there's beta cell death and dysregulation of the beta cells and insulin resistance. Then we have diabetes in pregnancy and gestational diabetes. But type 3C diabetes is pancreatogenic diabetes, where there is a physical destruction or breakdown of the pancreas. So it includes both structural and functional loss of insulin secretion in the context of exocrine pancreatic dysfunction. So kind of kicking off with some exocrine dysfunction, and then we have a co-loss of the beta cells in addition to that. So let's take a look at this in more detail. It's about 5 to 10% of diabetes, and usually people are misclassified as having type 2 diabetes. There's a diverse set of etiologies, like why does this happen, and what does that person start with where they get this 3C diabetes? Well, pancreatitis is the main contributor. As you know, with pancreatitis, there's inflammation of the pancreas, and the exocrine function of the pancreas kind of can attack and digest part of the pancreas. So there's extra exocrine pancreatic function happening, which can lead to inflammation of the pancreas and also can start damaging the beta cells of the pancreas. So the exocrine function leads to the endocrine dysfunction. And endocrine is the beta cells making insulin. That's how we differentiate the two. Okay, 70% of people post acute and chronic pancreatitis will express type 3C diabetes, where they'll see elevations in blood sugars, but they're also lacking in the exocrine function of their pancreas. So they might need medications to support that. Trauma. I had a friend who got in a car wreck and part of her pancreas was injured. So she had type 3C diabetes where her blood sugars were elevated because of damage to the exocrine and endocrine function of the pancreas. People with cancer, we might do a partial pancreatectomy or total pancreatectomy, which is more rare. But then again, we're going to see both dysfunction of exocrine and endocrine. Cystic fibrosis. So cystic fibrosis is usually it kicks off with a person is making extra mucus in their lungs and their pancreas is not able to make enough exocrine, hormones to help with digestion, but then it also leads to endocrine dysfunction. Okay, hemochromatosis, so extra iron in the blood. People with hemochromatosis, they often call it the bronze diabetes because they have a darker skin from having extra iron in their blood, but that extra iron actually damages the pancreas. And then they can have calculus in their pancreas and other rare genetic disorders. So when you hear this 3C diabetes, this is what they're talking about. And it can lead to elevations in blood sugar combined with exocrine dysfunction and lack of digestive enzymes to, break down foods. Then what is pancreatitis caused by? We've been talking about this a lot already, but it's caused by digestion of the organ from the pancreatic enzymes normally carried to the small intestine through the pancreatic duct. So here we have the pancreatic duct, and then we have the gallbladder duct, and then we have this common bile duct where they intersect. So if there's gallstones in the common bile duct, it blocks the pancreas from releasing its digestive enzymes to the duodenum. And what happens then is the digestive enzymes back up in the pancreas, and then the pancreas digested by its own enzymes. That's why we really want to, like if a person has gallbladder stones and they're stuck in the common bile duct, we are so worried that they're going to get pancreatitis. We need to treat it right away. So that is kind of a common reason behind pancreatitis, but there's other reasons too. How do we detect pancreatitis? Through elevated amylase levels and pain. Pancreatitis hurts really bad. Lower abdominal pain, often radiating to the back. But other causes of pancreatitis include the antiretroviral medications for HIV, alcohol ingestion, gallstones blocking pancreatic enzyme flow, elevated triglycerides. We're really worried about that. I work with several individuals in our clinic. They have elevated triglycerides, and we know that's co-associated with pancreatitis, cancer, injury, and other. So here's the thing. People with diabetes have 2 times the risk of acute pancreatitis. And really important, after an episode of pancreatitis, 1/3 of people after one episode will get pre-diabetes or diabetes. So, gosh, after somebody gets pancreatitis, we keep a really close eye on their blood sugars, knowing that about 25 to 80% of people with chronic pancreatitis will have destruction of their pancreas and develop type 3C diabetes. Pancreatitis is an exocrine dysfunction that disrupts the global architecture and physiology of the pancreas, resulting in both an endocrine and exocrine dysfunction. And I was teaching a class the other day, and a gentleman came up and he goes, "You need to talk more about exocrine pancreatic insufficiency." And I'm like, really good point. And I was just actually coming up to the slide on exocrine pancreatic insufficiency. But people that are not making enough of these enzymes from the pancreas, exocrine enzymes, often they don't have an adequate digestion of fat. So since it can't digest fat because they're not getting those exocrine enzymes into the small intestine, the duodenum, then what happens is they have fatty stools. And I use this cupcake to try and illustrate that. And they might actually experience abdominal pain after fatty meals. It can happen with both type 1 and type 2 diabetes, often associated with 3C diabetes. And these individuals might need to take fat-soluble vitamins, enzymes, medications that replace these enzymes. Avoid smoking is really going to help. And to protect the pancreas, avoid excess alcohol. So all these different factors can really help them live successfully with this. But I think the first thing is recognizing it. And many people may have this exocrine pancreatic insufficiency and not know to share their symptoms with anybody. So if somebody says to you, oh, they have diabetes or they've had pancreatitis and they have fatty stools, it's certainly something that might resonate with us. Let's investigate this further. Well, speaking of pancreatic dysfunction, pancreatic cancer is something we really want to be on the lookout for. Now, one of the things that's so tricky about pancreatic cancer, it's hard to catch it early. But what's one of the early signs of pancreatic cancer? Elevated blood sugars. So, if people are having elevated blood sugars and severe weight loss, more than would be expected for, diagnosis of type 2 diabetes, and they're having other symptoms, we just want to keep a close eye. Abdominal or back pain, jaundice, weight loss, nausea, change in stool, recent onset of diabetes. The thing is, pancreatic cancer is deadly. In 2023, there were 64,000 people diagnosed and 50,000 people died of it. So you can see the prognosis is not that great. So if we can catch it early and provide intervention, it can improve the outcomes. Pancreatic cancer actually accounts for 3% of all cancers in the US, but 7% of cancer deaths. So as diabetes educators and specialists, I think we can just be aware of this and just these are things we hold in our back pocket that we might recognize that hasn't been detected before. Well, we're moving on from the pancreas now to the liver. And maybe you've already heard about this. I won't spend a ton of time on it, but we're changing the nomenclature on the way we talk about fatty liver disease. And the reason is there's a lot of stigma when we say, oh, a person has fatty liver disease. So the American Association of the Study of Liver Diseases, the gastroenterologists, wanted to create a new way of talking about it. Now, the American Diabetes Association hasn't accepted this new language. I'm not sure if they will in the future, but I just want to share it with you because, as you all know, we talked about we want to keep things person-centered. And I think the new language is more person-centered and more considerate of the individual living with extra fat in their liver. So the old term was fatty liver disease. The new term is steatotic liver disease. Instead of saying non-alcoholic steatohepatitis, which is NASH, I think this is so much better actually, because that doesn't really tell you much. It just tells you the person has liver inflammation, but it's not from alcohol. This tells us something different. It says, oh, they have metabolic dysfunction. So they have insulin resistance, oftentimes diabetes, associated with steatohepatitis, with liver inflammation. So it kind of tells you the origin story. Instead of saying non-alcoholic fatty liver disease, we'll just say MASLD, metabolic dysfunction associated steatotic liver disease. So it's MASH or MASLD. So that's easy to remember. But what is so important for us to know, and gosh, y'all, when I think about diabetes, I just used to worry about hyperglycemia, but now we're just thinking about all the different body systems that are affected by this insulin resistance and coexisting hyperglycemia. But we know that steatotic liver disease is diagnosed, or MASLD, metabolic dysfunction associated liver disease, is when the fat, I just call it steatosis for today. Steatosis is when the fat reaches 5 to 10% of the liver's weight. So when that liver is 5 to 10% of the weight of the liver is fat, then that person has steatosis. Now, it is prevalent. MASLD is prevalent in 70% of people with type 2 diabetes. 70%. It's a lot. Now, do all of those individuals go on to get steatohepatitis? No. of those, about 50% have the more intense version, steatohepatitis, where there's actually changes in the liver. And then 12 to 20% get fibrosis, where that liver becomes more fibrotic and it shrinks and it loses its functionality. So we need to evaluate for liver fibrosis for those at high risk with type 2 diabetes or pre-diabetes with cardiometabolic risk factors, and I put those here. If they have increased BMI, if they have hypertension, hyperlipidemia, elevated triglycerides, and elevated blood glucose levels, if they're 50 years and older, and if their ALT and AST, their liver enzymes, are 30 plus. There's more precise measurements for these, but when I look at my lab results and I look at ALT and AST, the lab might have different normal values, but what they're saying is anything 30 or greater is something we want to look at. So we're looking for ALTs and ASTs. And then if that person has elevations, we are going to send them for imaging or ultrasound to evaluate. So here's kind of how it all starts. You just first have steatosis, a fatty liver, and then you go over to NASH or steatohepatitis, where now we're having fat plus inflammation and scarring, until where we get to cirrhosis, where scar tissue starts replacing liver cells. And then a person with cirrhosis is much more likely to move on to cancer of the liver or also liver failure. And gosh, we want to catch it here, because if we can catch it just with the steatosis, then we can start turning around and we can actually help improve liver health. And so now when I'm working with people with a BMI of 30 or greater and diabetes, and especially if they have larger waistlines, I'm really thinking and I'm looking at their liver enzymes, but I'm thinking if they don't have steatosis, they're walking toward it. So I'm going to do everything I can to help them with moving their body and eating healthfully. And that's what we do for everybody with diabetes, right? It's just a way to get healthier. But I have in the back of my mind, let's really protect that liver. Let's take a look. EV is 58 years old with type 2 diabetes and a BMI of 33. In addition, EV has hypertension and hyperlipidemia with elevated liver enzymes. To determine if EV is at risk for liver fibrosis and cirrhosis, which of the following would provide a risk calculation? Will we do a UACR, a FIB4, a GAD, or weight divided by the square height in meters? So if they have, this launches poll. Well, I did not create a poll for this, so we're going to do this together. So if they have hyperlipidemia, elevated liver enzymes, a BMI of 33, and type 2 diabetes, gosh, we're really worried about them. So one thing we can do that's super easy, and I do it all the time in the clinic, is a FIB4 test. So let's talk about how do we screen for NASH or steatohepatitis. So what we can do now is we can do a quick estimate. The person has to be 35 years and older, but what we're going to put in, you just could do FIB4 calculator on any Google search and it will come up. You put in their age, and then you put in their AST level and their ALT level and their platelet count. And that gives us a number. And this number is 2.61. And that tells you the risk of hepatic cirrhosis, how fibrotic their liver is. So 2.61, here's the different risk levels. You can see that 2.61 is intermediate. And this person then would be recommended to have further evaluation via ultrasound or a fibroscan to see if they have liver disease. And if it's, of course, 2.67 or greater, they need to have imaging to see what's happening. But I wanted to tell you that the American College of Gastroenterology considers upper limit of normal ALT levels here. They differentiate for men and women. Interesting. So I think we're still working this out. We're trying to figure out what is the best approach, but the FIB4 screening shows up in the ADA standards of care. And if that person has an elevated level, we could send them for a scan, an ultrasound, MRI, or a fibroscan or a liver elastography. And a fibroscan, if you haven't heard of it, super easy, takes like 10 minutes, non-invasive. All they do is they put this probe on the liver, and the probe sends a pulse of sound waves, which feels like a gentle vibration on the skin. And what they do is they take the average time for the sound waves to bounce back is converted into a measurement of liver stiffness. So they put the sound wave through the liver, and through mathematical calculations, they figure out how stiff is the liver, how much fibrosis, and then they give it a score. And based on that score, we kind of know where that liver is at. And I know they have fibroscans that are traveling across the country, and just the clinics utilize them to evaluate liver disease in their clients. But what can we do to help with steatosis, or when that fat in the liver reaches 5 to 10%? We can do a lot. Strength training, yoga, tai chi, walking and aerobics. Gosh, if people are already walking, adding strength training and muscle mass can make a big difference. Thoughtful eating, more fiber, less processed foods. We really want to decrease added sugar, that fructose we want to, and white sugar, added sugar. If they can decrease it, it's a big help. Less alcohol, see a registered dietitian. And then we do have some pharmacologic interventions. Believe it or not, Actose, which is a thiazolidinedione, has been shown to actually reverse liver disease at low dose, 15 milligrams. Actose can cause fluid retention and worsen CHF, so we avoid in that group. But for a person who's a candidate, it can make a big difference. The GLP-1s and those have been recognized by the American Diabetes Association to help decrease fat in the liver, because it helps people lose weight, and there might be some other factors involved too. Statins are going to help decrease the fat in the liver too. So we have pharmacological interventions, we have lifestyle interventions, and we want to engage in prevention too, keeping a close eye on the risk factors for cancer and decreasing inflammation. Okay, we're almost there. You're doing so great. So now we're going to go from the ileum to the anus, and here we are with our little appendix right here, and there is our large intestine, and we have the ascending, the transverse, and the descending colon going to the rectum. Now, the ileum is the last 2 meters of the intestines, and to move food from the ileum to the cecum, the food passes through the ileocecal valve. And the reason I bring this up is because the appendix hangs out near this juncture. Now, the appendix actually has lymphoid cells similar to our tonsils. It's so cool. So it's collecting bacteria, bad bacteria, it's going to identify it. But sometimes if the appendix just gets too full of bacteria and white blood cells, it can lead to appendicitis. But it does have a noble function. It doesn't get much credit. And then we have the sigmoid colon, which kind of turns on its side to enter the iliac fossa, then to the rectum. And then at the anus, we have 2 sphincters, internal and external. And the external anal skeletal muscle is under voluntary control, but the internal anal muscle is not. So it's this real orchestration of these 2 sphincters to have a bowel movement. And if one of these sphincters is not working correctly, it can really lead to problems. So I wanted to say, we ask people about their bowel health, and some people might say, gosh, I have diarrhea. And then I might say, oh, how often do you go to the bathroom? They go, oh, once a day. So diarrhea, we actually have a definition for it: 3 or more bowel movements a day. And when people have diabetes, we want to think, what could be causing this? Metformin is sometimes the culprit, and people don't even know that they need to report this diarrhea, but we want to know about it, because diarrhea is a sign that the body is out of balance. The intestinal health is really struggling. So here's some interventions: whole grains and fiber, drink water, get regular exercise, quit smoking, limit alcohol, take medications as necessary, of course, with the provider. And then some causes: elevated glucose. This is interesting because remember I was saying earlier, elevated glucose can stimulate stomach emptying. So for some people, it can stimulate diarrhea. Neuropathies, metformin, some GLPs can cause it. Celiac, yeast infections, small bowel overgrowth. Exocrine pancreatic insufficiency. Maybe this is a sign they don't make enough of those digestive enzymes. Irritable bowel syndrome. and sugar-free foods. A lot of those sugar-free foods have those sugar alcohols that can cause it. What about constipation? A lot of people tell me I'm constipated. I'm like, tell me how often you go to the bathroom. And I go, well, like every 1 or 2 days. Okay, it's not, it doesn't meet the criteria for constipation. It's defined as less than 3 bowel movements in a week. But it might feel uncomfortable for them. They might want to go more frequently, so we can have a conversation around that. But it is more common in diabetes, again, from autonomic neuropathies. GLP-1s can contribute. Treatment, gosh, it's similar, right? Getting glucose to target, fluid, fiber, bulking agents like psyllium and Metamucil might be helpful. They might need laxatives. And then bathroom habits. How do they sit on the toilet? And I do want to say our body posture when we sit on the toilet can make a big difference. Even if people can put a small stool under their feet when they go to the bathroom, if they have constipation, that can help correct the alignment of the rectum and can actually, and the anus, and help with bowel movements. So just that simple reposturing can make a big difference. Originally, humans squatted when we went to the bathroom, and we're kind of designed to squat to have a bowel movement. And since we invented toilets, it's kind of disrupted that posture. So one way to fix that is with the stool. Okay, so we're going to talk some more about poop. Look at your poop. I ask patients, like, what does your stool look like? They're like, I don't know. I'm like, okay, you got to start looking at your stool. And, it's a real reflection of our intestinal health. So if you haven't seen this yet, let me introduce you to the Bristol stool chart. And here are hard, we call these, rocks. That's what I say. Do they look like rocks? Are they lumpy? Does it look like a sausage? So we want the sausage shape is kind of the A+ poop. And then the blobs and the mushy stool and liquid is what we're more toward the diarrhea. So, looking at, smelling it, looking at it, like if it's red or if it's black and tarry, if you're taking iron pills, it might have a greener look. That is helpful to share with providers if it's not, looking like it usually looks. So I really encourage people to take a look. And I had this fun what's it called? Like a game we played in a class I was teaching, and how many words for stool? Now this is kind of interesting. Here's all the different words we use for a bowel movement, and so the funny thing about it is the more words we have for something, the more we're interested in it, and the more we engage with it. So you can see having healthy bowel movements and our bowel health is really important for us. And you can just kind of see the different wording that different people could use to describe it. Okay, so promoting colon health. We want to nourish our gut bacteria, get enough sleep, keep active fluids, consider alcohol, quit smoking, go outside, thoughtful antibiotic use, meditation. All right, I just want to say something about your gut bacteria. They need sleep and they need us to have moments of rest because that's when they get to rest too. So, think about your gut bacteria. And another important reason to think, another way to be kind and generous to your gut bacteria is to eat more fiber. I mean, beans are so magical. You've all heard the song, beans, the magical fruit. The more you eat, the more I'll let you fill in that word. But we're tooting because the gut bacteria are loving it and they're breaking down those beans for us. But just this can of chili has 10 grams of fiber for one serving, and there's 2 servings, 20 grams of fiber. So we're trying to get 30 grams of fiber a day. Most of us are lucky if we get 20 grams of fiber a day. Avocado is such a nice source of fiber. And we do know that eating fiber-rich foods is associated with a lower mortality for people with type 2. And fiber intake is inversely associated with type 2. The more fiber you eat, the less likely you are to get type 2 diabetes. The less fiber, the more likely you are to get diabetes. Fiber is healing, it's nourishing, it feeds our good bacteria, it increases the butyrate acid in our intestines. Really, really important. We can encourage people, like when we do a diet recall, we can hear the foods they eat and figure out ways to help them incorporate fiber-rich foods, vegetables, fruits, whole grains into beans, lentils, into their meal plan. As it turns out, Grandma was just ahead of her time. I like that. So how do we get to better gut bacterial health? We want to eat more prebiotics that feed our good gut bacteria. And I've listed those here. And then probiotics. And these foods contain healthy bacteria like bifidobacterium and lactobacillus that are just provide our intestines and our body with these healthy bacteria. And lots of studies are showing that people who eat yogurt on a regular basis, it actually can decrease inflammation and support healthy weight. So here's some great fermented foods that people can enjoy too. You know, kefir is fermented milk, and you might say kefir, or the word in Turkish, keyif, which means feeling good after eating. So kefir is lactose free, and people of lactose intolerance can enjoy it. It has a little bit of a bitter taste for some people, or sour might be a better word. But look at all these live active kefir cultures. So people ask me, you know, what about taking probiotics or the pills? It's just we don't really have good quality control in a lot of those, and we're not really sure what's in some of those. They're not overseen by the FDA. And so eating the live active cultures might be a better choice for someone. For most people, as long as, you know, we have to think about if they're immunosuppressed in any way and be cautious around that. Well, to wrap up, I just thought I would kind of summarize what I've talked about with gut bacteria. I have a little poem that I wrote. It's called 100 Trillion Friends to Call Your Own. And I'll wrap this up and then I'll let you go. So I'm going to go ahead and say it for y'all. From the way back when to the current time, man and bacteria have been intertwined. Start with your head, it's a happening place. There's staphylococcus all over your face. Next to your gums, teeth, and mouth, there's streptococcus inside and out. Now to your stomach to keep the pH, H. pylori is on the case. Inside your intestine, 30 feet of tube, 3 pounds of bacteria digesting your food. From Bacteroides to keep you lean to Firmicutes, a junk food digesting machine. Periodontal, another bug on the scene, breaking down fiber, veggies, and beans. Lactobacillus is a newborn's friend, lining birth canal from tip to end, down to your feet and between your toes. That's where a lot of Pseudomonas grows. Short chain fatty acids, you want to keep them around because protects gut mucus lining from breaking down. So here's my message: always nourish your gut with fresh food, grains, veggies, beans, and nuts. More kefir, miso, sauerkraut, kimchi, less sugar, and fast food to keep away disease. Breastfeed, get dirty, limit antibiotic use, and let newborns come out through the natural chute. From the way back when to the current time, man and bacteria have been intertwined. So be reassured you are never alone. You have 100 trillion friends to call your own. Thank you so much for joining us. This is Beverly Tomasian. I'll hang out to answer any additional questions. And I hope this information was stimulating and it brought some new, fresh ideas to the plate for you, to use a food analogy. And I hope, you digest it well. And I hope that we see you again soon. Hey, happy National Diabetes Month. Happy World Diabetes Day. And I hope that you'll be joining us again for a future webinar. This is Beverly Tomasian signing off.